Good evening. Welcome to this group discussion on short bowel syndrome. Short bowel is not a very common occurrence, to be honest, in a surgeon's life, but we need to understand, being surgeons who deal with the bowel a lot, the surgical importance of the bowel and an extreme situation where you do not have enough bowel to serve its purpose. That's a short bowel syndrome. So when we have a discussion, we must be learning about what exactly is a short bowel. We must understand the normal anatomy and physiology and then the pathophysiology. There are certain unique metabolic issues that occur with a short bowel, which goes beyond the bowel, the limits of the bowel itself. And we must understand the management principles. And as surgeons, we must have some idea of the surgical options that are available for us when we deal with small bowel, short bowel syndrome, even though it's known, well known, that these options are not very often used. So what we need to first understand is to know the normal, relevant anatomy and physiology. I say relevant here because I'm not interested in what the anatomy books say, the anatomy books, basic anatomy books and the physiology books say, but we need to apply it for our surgical pathophysiology. All right. So let's start with the first years. Supreet, tell me, what do you know about the anatomy of the small bowel?
Good evening, sir.
Good
Uh,
evening.
a small bowel, the length of the small bowel in an adult is around 275 to 850 centimeters, sir.
Okay.
Uh, and it mainly deals with uh, 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 absorption of fluid and oral fluids and saliva, gastric and biliary and pancreatic secretions, sir.
Good.
Uh, and Around 9 liters of fluid passes through the small bowel, and 7 liters of fluids will be absorbed to small bowel only, sir, and 2 liters from the large bowel.
Very
Yeah,
right.
yeah. And the large bowel helps in the absorption of only the water and the electrolyte, and
Okay.
the most of the nutrients are absorbed by the small bowel only, sir.
Okay.
Uh, and the small bowel is helping the absorption of vitamin B12 and intrahepatic uptake of bile salts in the
Right.
terminal ileum, sir.
All right. You've obviously done your reading, and that's good. So there's a lot of fluid that's absorbed by the small bowel. Little less amount of fluid, maybe a fourth of it or maybe a third of it absorbed by the large bowel. So it's important that you need to have that length of the bowel if you want to maintain your nutritional status and your fluid and electrolyte status. Now, what is the role of villi? How do you think the villi increase the absorptive surface? Any idea?
Yes, the area of the absorption will be
Mhm.
increased because of the
By how many folds? That's the question. 40
no.
fold. All right.
Okay,
And if you consider the microvilli, it runs into hundreds.
okay.
500 times the surface area will be increased. Now, why am I even talking about this in the context of a short bowel syndrome? Even if you have a small length of the bowel, okay, if there's a short bowel, the adaptation that occurs is greatly facilitated by the increase in the surface area that is affected by the villi and the microvilli. Okay, so that is how the adaptation occurs. The bowel itself does not become longer. It may hypertrophy a bit, it may become slightly longer, but the real adaptation occurs at a microscopic level. And that takes time, that takes a few months, but that's where the absorptive surface increases. So, as you rightly said, the normal length is about 300 to 800. Short bowel is when it is less than 200 centimeters, or because you see a big range here, if the bowel is 25% of the normal for that person. So if he has, only 500 centimeters of bowel, 1/4 of it is what is considered short bowel. Okay. But understand that the proximal small bowel, jejunum, is the most important part for absorption. A lot of things happen in a lot of places, but that's the most important. And as you rightly said, okay, the magnesium, you didn't mention magnesium, but B12 and magnesium are absorbed in the ileum. All other things are absorbed in the jejunum. You mentioned only water and electrolytes, but the colon has a role in absorbing fatty acids and vitamins. The source is not food that is eaten, but the breakdown of the carbohydrates and the fiber that is present in the large bowel by the local flora, by the large amount of bacterial load that is present in the colon. Okay, that is the importance. So when you lose parts of the bowel, all right, then you have problems. Problems not only of nutrient absorption, fluid and electrolyte absorption, but there are certain other metabolic disturbances that take place, and we'll be talking about it as we go along. So the importance of short bowel lies in it being a cause of chronic intestinal failure. We talk about kidney failure, we talk about heart failure, but we hardly ever talk about intestinal failure, but that's a very real entity. And there is a definition for this chronic intestinal failure. Ainash, can you give me the definition for this? Or at least the essential meaning that comes out of the definition.
So, a state wherein the individual's GI function is inadequate to maintain his nutritional or hydration status, fluid status, and that is they are not able to maintain this without any additional supports.
Mhm.
Is what
You have to be a little more specific. What kind of additional support?
The intravenous or enteral supplements, like
Not
parenteral.
enteral, not enteral. It has to be
Parenteral.
parenteral. Yeah. All right. So
Yes.
intravenous supplementation, that is the definition of chronic intestinal failure. If you can maintain somebody's life with nutritional management where the GI tract absorbs what is required to keep him alive, it's not intestinal failure. It has to have a requirement, at least temporarily, if not permanently. Many times it is temporary. Temporarily, it needs intravenous supplementation. That is the definition of chronic intestinal failure. It could be either acute or chronic. It's arbitrary, but for general purposes, it is defined as a period of less than or more than 6 months. If it's less than 6 months, it's an acute intestinal failure. If it's more than 6 months, it's a chronic intestinal failure. Many times you can get off the parenteral support 6, 8, 9, 12, 24 months later. But there are certain situations where the parenteral support has to be permanent. All right. So when we talk about etiology, what do you think causes chronic intestinal failure? Praveen.
Hello, sir.
Yeah. What
Sir,
are the causes of chronic intestinal failure?
It can be due to chronic is like Crohn's disease.
Yes.
To mesenteric ischemia, radiation enteritis, and
Yes.
post-operatively due to.
I keep saying you must classify these things, okay, for you to understand the pathophysiology and to make it a complete list. And even when you answer in an exam, not only it's very useful clinically, but when you answer in an exam, it'll even more impressive when they know that you know what you're talking about. So when you talk about Crohn's disease and radiation enteritis, what are you thinking about? Mucosal disease, right?
Yes.
Where absorptive capacity is lost. Yeah. So what else can cause that kind of what other classification can you have? What for a surgeon, are you more worried about the initiation or the beginning of a Crohn's disease, or you're worried about something else? You're worried about the length
Bowel
of the bowel,
dissection,
right?
yes.
We went on talking about the length. Defined it as being 25% of the normal, if it is less than that. Okay, so the length is important. So what are the situations where the length becomes very short? As a surgeon, you're forced to take out bowel. What are those conditions?
Mesenteric ischemia.
Okay. How can you stop so quickly? Nikita.
So intestinal atrocious malignancies.
Okay. Would you really get a massive resection in malignancies? Very unusual. Last on the list.
Sorry.
Ischemia is one. Okay. Mesenteric ischemia. Where else
Yes.
can you get ischemia?
Trauma, sir.
Sorry?
Volvulus, sir.
Volvulus. Quite right. Volvulus. Trauma is again unusual, but volvulus is very common, particularly if you have, congenital abnormalities and malrotation of the gut. They get a volvulus and a whole lot of the bowel goes on. Okay, and of course, diseases like Crohn's where you have to have resection. You can have intestinal failure in Crohn's even without resection, but it may be that you have repeated need for repeated resections and that may end up with it. So length of the bowel is one. What else? You mentioned about mucosal disease. We talk about extensive lymphoma, extensive Cox also, for example. All
Desmoid
these,
growth.
sorry?
Desmoid growth, sir. The complete intestinal.
Desmoid. Desmoid is in the abdominal wall, right? Yeah. Yeah.
That is mentioned as one of the important
Desmoid.
things. Sir.
Desmoid of the,
Yes.
Sorry,
go on, Ravi.
we have seen about two or three cases that have come from very reputed hospitals where the desmoid was in the root of the mesentery, and that sort of constricted the blood vessels, and when they tried to resect it, they ended up resecting virtually entire small bowel, and that caused intestinal failure.
Really is
But
first time,
I don't
honestly,
think
the
they
first
should.
time I'm hearing about it.
But I
Okay.
think they shouldn't mention.
Desmoid as a tumor in the root of the mesentery must be very, very unusual. Anyway, okay.
So,
Okay.
so in Bailey, they have mentioned desmoid being one of the one of the diagnoses.
But don't mention it as
I would put it at the end of the list,
end
honestly.
of the list.
There are much more common conditions. Okay. What else? Go on. We can't be struggling with the causes this much.
Necrotizing enterocolitis, sir, in children.
Look at this. Look at this. Look at this. So simple. Okay. If you have a gastrocolic fistula for some reason, why would you get a gastrocolic fistula? Can anybody tell me naturally?
Diverticulosis, sir.
Very rare, much more common than that. A natural abnormal communication between the stomach and the colon. See a stomach, see a colon, okay, can adhere in an advanced state, can locally advanced state can adhere, and then you get a fistula, okay, you get a jejunocolic fistula, which happens again in post-op situations and Crohn's. Obstruction, carcinomatosis and adhesions can cause obstruction. Some kind of a blind loop syndromes like situation with bacterial overgrowth again causes intestinal failure. You cannot forget dysmotility. Okay, pseudo obstruction, even though more common in the colon, can occur in the small intestine. It can be global. The whole of the GI tract can be involved, and that's one of the most difficult conditions to treat. And the mucosal type that we spoke about first, okay, protein losing enteropathy, radiation, chronic inflammation, like even Cox or Crohn's and things like that. So please remember, this is the way in which you classify the etiological groups. And under each of those groups and subgroups, you have conditions which cause the actual problem. And a lot of them are medical causes. Remember, not all of it is surgical. And that's the point I was making when I said Crohn's and protein losing enteropathy and things that pseudo obstruction can cause all these issues. Okay. So we then think of phases in small bowel syndrome. We actually mentioned it in the beginning of this discussion itself. You just have to put it in the proper perspectives. Okay. So tell me, Sai Likit, if you have read up about it, have you heard of phases of short bowel syndrome?
Hello?
Yeah.
No, sir.
You have not heard of it?
No, sir. No.
Did you read up the topic today before coming?
No, sir. No.
No. You should read and come. Okay. Very
Yes.
important.
Yes.
Samir,
Yes.
go on.
Hello.
You know about
Yes,
the
sir.
phases? Yeah.
Sir, acute adaptive phase and then finally the intestinal failure phase, sir.
Excellent. Not maintenance, okay? Not adaptive. The acute phase lasts about a month or so, where there's a huge loss of fluid and electrolytes, consequences of malabsorption, and one of the metabolic effects probably mediated by the enterogastric hormonal churn, if you want to call it that, that feedback mechanism and things like that. You have a big gastric hypersecretion. The adaptive phase may take about a year or two. Okay, there is an increase in the absorptive surface. There's a slowing of the transit and a natural hyperphagia. The patient tends to eat more and compensate for the excessive loss and the excessive or the reduction in the absorption. Okay, so that is the adaptive phase, and then you have, of course, the maintenance phase, which goes on forever, and that's when you have to chip in and perhaps give him supplements to keep him alive and make sure that he doesn't get into various deficiencies. So this is the phases that you see in a short bowel syndrome. Presence of nutrients. This is a very important statement, and that's why I put it up as a separate slide. Is nutrients and digestive juices is important for in the intestine is important for adaptive process. What it means is that you don't ever keep them completely NPO. Unless you give them some substance to go and stimulate the bowel in its lumen. You need to have some food in the lumen. Unless you do that, it won't adapt. And so even if you are giving parenteral supplementation, which by definition is required in a chronic intestinal failure, even though you're give him something to eat, what is it that we have to give to eat is something we will discuss as we go along. So remember that there should not be complete NPO even in a short bowel syndrome. Can you think of another problem of outside the small intestine but inside the abdomen of keeping somebody NPO? It happens very commonly in orthopedic wards, can happen in surgical wards also. If you keep somebody completely NPO, what can they have?
Cholestasis?
Very good. All right. It is acalculous cholecystitis and cholestasis that can happen. So there's another reason, even in a patient with ileus, it's good to give them a little bit of something to eat. And what that little bit of something is, as I said, we will discuss. Now, we agreed that generally less than 200 centimeters of small bowel is being present is considered a short bowel syndrome. Also remember the other thing, I'm repeating it so that you remember, 25% of the existing, less than 25% of the normal length of a given patient. It could be less than 200 centimeters. It could even be more than 200 centimeters sometimes. But that's another definition for short bowel. But if you have generally 200 centimeters, you will have enough to survive. Okay. But there's a statement made below that saying that ileocecal valve and the presence of colon are important. Now, how do they impact the problems that we see in short bowel syndrome?
So ileocecal valve will slow the transit of the GI contents.
Correct.
And
so it stays longer in the small bowel for it to absorb, and it gives a smaller osmotic load to the colon. Okay. And so the colonic function also will be better. Small bowel absorption also is better. Correct. What about presence of colon? How does that work?
Sir, in the terms of absorption as well as the
Absorption of what? Fluid and
absorption of the
electrolytes.
nutrients.
Fluid
Yes, sir. Yes, sir.
More than the nutrient, straight away fluid and electrolytes.
Fluid and
So
electrolytes,
that
and
makes your
also
life so much easier. And nutrients, as we said, it can have,
by the flora.
by the flora, you can have some fatty acids and some vitamins being absorbed. But remember, glucose or carbohydrates and proteins are still not absorbed. So it transpires that if it is less than, if it's 200 centimeters as a standard, if you have the ileocecal valve, and if you have the colon, then you can get away with a shorter length of the small bowel. All right. So can you get do you guys know how much it is? Can you give a guess as to what is the minimum required for survival if there is ileocecal valve and if there is both
50
ileocecal valve and
centimeters.
colon? Sorry?
150 centimeters.
All right. This is it. 120, somebody said. Okay. So end jejunostomy with no colon in continuity, you can get away with 115 centimeters. If you have a jejunocolic anastomosis, that is no ileocecal valve, it can be 65 because the colon is working. And if you have a jejunoileal anastomosis with an intact ileocecal valve and the entire colon, can be as short as 35 centimeters. Okay. Remember, these are dimensions for compatibility with survival. But you have to have parental nutritional support and give them time to adapt. And as I said, the adaptation process may be anywhere between 6 to 24 months. Right. So these are the dimensions or the approximate length. Don't go by actual values. A ballpark figure. Ballpark figures is what you have to be thinking of. So this is how you can think of. Why is this knowledge important? Nikita.
So, if you want to go for a radical resection for the decision making on table.
Very good. Okay, that's the idea. You're a surgeon. You're now left with a dead small bowel. Then you have to decide. These are the two things you must have in mind when you take a decision. What is the length of the small bowel that is gone? Is the ileocecal valve intact? Is the colon intact or not? These are the three main questions you have to have. And if you find that with an end jejunostomy, with no colon in continuity, you have less than 60, 70 centimeters of bowel, then the person is unlikely to survive. So it will be cruel to put him through a resection and put him through a whole lot of things. And so this is the important thing where you must have a global view when you meet with an ischemic bowel, a dead bowel, where the patient may or may not survive. Okay. Ravi, anything to add so far?
This one, sir. One is with Crohn's disease, and generally, what we found in the intestinal failure unit we were working was that people, would resect more than what is necessary. So you don't have to, like malignancy, you don't need to have margins that are free of disease and things like that. So you resect as little as possible. So that is very important because many times you may have to do repeated resections. See, the rule of the thumb with Crohn's disease is a third of them will remain the same, the third of them will get better, and third of them will keep deteriorating. So you can't keep on resecting. So when you resect the least minimum possible so that you can, most of the time you would have first of all resected the terminal ileum and ileocecal valve because that is the commonest area that is involved. So you have to be very careful. And second thing is whenever there is a post-operative complication, you have to be very careful about going in because what we have found was that when you go in at a very early stage, if you can tide them over without operating, you should try because majority of the bowel that is damaged is because of your surgical trauma that happens due to a lot of adhesions and because the disease is already at its highest. So if you can manage the patient, give the bowel rest, put them on TPN and manage them without operating, majority of the time you can actually avoid resection. So with Crohn's disease, you have to be extremely careful when you go in, and when you go in, you try and resect as little as possible. That is one thing. Second thing is other cause of though it is temporary, whenever there is some either a blowout, duodenal blowout due to a bad duodenal ulcer or post surgery, there will be a very high output fistula, and that in that situation there is temporary intestinal failure. You can overcome that by after you have tied over the immediate aftermath of the problem. You can get the anatomy of the distal bowel, and if the distal bowel is healthy, you can cannulate the distal bowel and feed them. And then while you are giving TPN, slowly that bowel can take over, and then you can.
Yeah. We are coming to the treatment part a little later. Yeah, fair enough. Okay, I agree about the Crohn's resection. You have to be conservative. The average number of operations in a Crohn's patient is 2.5. Okay, so if somebody needs a resection for Crohn's once, it's almost certain that they'll need it again a few years later, maybe another time a few years later. So you have to be conservative with your resection in Crohn's. That's right. So what are the mainstay of treatment? What are the things that you would be thinking of? Nitya, why don't you tell us?
So we have to first maintain the nutritional status.
Very
That is
good.
one thing.
Yeah.
And also, whatever bubble is there, we should maximize the absorption. The capacity should be maximized.
Okay, facilitate adaptation. All right.
Yeah.
I would agree with that. What else?
And to prevent further resection, like further.
No, you can't do it. If it comes to that, comes to that. But you want to treat the metabolic complications. And there's always some complications of the support that you give. TPN, believe me, is something which is fraught with many issues, particularly in a country like ours. You have issues even in the West, but in our country, if you have long-term TPN, if you have to do it, there are many issues. So to treat the complications of the support, this is the mainstay of treatment. Above all, in the acute phase that we talked about, supportive treatment, fluids, electrolytes, and nutrients. That is the kind of support that you have to give. Okay, and there are some special issues in SBS, short bowel syndrome, which has a metabolic implication. One of them I mentioned was gastric hypersecretion. Like that, what else do you have?
Refeeding syndromes.
That is not a problem of the SBS itself. Okay, it's a problem of the support. I agree, but without doing anything,
Gastronemia, sir.
Yeah, I mean hypersecretion. That's what I said. Yeah, that's why you get hypersecretion of the gastric acid. That's one. What else do you have?
Oxalate.
Diarrhea.
Somebody talked about the biliary tract, right? We talked about
Cholestasis.
So what happens if you have cholestasis?
So impaired fat absorption.
Cholestasis. What happens here?
Oh, gallstones
The
and
bile
Gallstones. You form gallstones. And internal ileum, we didn't specifically mention it that state. Just like B12, there is also something that happens with oxalates. Okay, so what happens? Yeah, you get kidney stones. We mentioned that magnesium is absorbed in the ileum. So when the ileum is gone, what happens?
Hypomagnesemia.
Yeah, it's all very, very simple stuff. Okay. And so you have liver disease with cholestasis, you have gallstones, you have nephrolithiasis that happens, acid peptic disease, hypergastrinemia that we mentioned, hypomagnesemia, lactic acidosis. And chronic acidosis gives you metabolic bone disease. You dissolve your bones if you are chronically, acidotic. Okay, so these are the special issues. And when you're dealing in an acute phase, all these things may not happen. But after the acute phase, which is 3 to 4 weeks, then you have to think of all these issues when you're supporting a patient with a short bowel. Okay, that's a very important thing that you must bear this. This is an important slide. This is what I said. It's not just nutrients. Nutrient support is very important. It keeps the patient alive. I'm not taking anything away from it, but you must have issues in mind that all these things can happen, and you've got to be specially addressing these issues. And there are ways of addressing these issues, which we will discuss as we go along. So you need a multidisciplinary approach. Okay, we had what was wrongly called hyperalimentation teams, which when then correctly they started calling them nutrition support service, NSS. Okay, it has all these people: physicians, nurses, nutritionists, stoma therapists. Many of these guys will have stoma, pharmacologists. You need them, and in the nutrition supports team that I was in Boston, it literally was all these people. All these people were there, and we used to have regular meetings, so-called ward rounds around a table, when all these people had some input or the other in patient care. So it was really a good experience, but extremely expensive. Even the West cannot afford it. So in India, as a surgeon, as a leader of the team, you sort of do the role of all these people. Maybe you will have a stoma therapist and a nutritionist, but the rest of it you usually manage yourself. Now, treatment-wise, what are the steps of treatment based on these aspects that I mentioned? What are the things that you would think of? Sanya.
So initially, to start with the nutritional management that we thought about, sir, all the vitamin deficiencies and all the other deficiencies that the patient is
when do you
facing,
think the vitamin deficiencies and the trace element deficiencies kick in?
Sir, after around 4 to 6 weeks, sir.
Yeah, about that time. It's difficult to be very precise, but yes,
sir.
You're not worried about vitamins and trace elements.
Yes, sir. Initially, we are about the fluid.
Month. Yeah, fluid, electrolytes, and food, nutrition.
Food, yes,
carbohydrates, proteins, and fats. Yeah,
fats. Correct, sir. So we can manage this nutrition in two ways: either enteral and parenteral. Enteral, we can ask the patient to have food, but the frequency of the food intake should increase, sir. And possibly if we can include complex carbohydrates.
Smaller, more frequent meals is what you're saying. Sir. But do you think they can really, in a short bubble, eat rice and sambar and whatever else?
So not immediately in the beginning.
So what would you do? What can you give orally other than these complex carbohydrates or full proteins? So what can you give instead? Which a patient can tolerate or absorb a little better?
Elemental diet, sir.
Okay.
Yes.
Okay. Is there anything between a regular food and elemental diet? Anything between that? There is, and we'll talk about it. So I'm talking about the basic steps. Nutritional support is the main one. You can give medication for various causes.
Yes, sir.
And I put surgery as a very small circle, okay? Because it really has a very small role. And to be honest, I've not done a single operation. I've seen quite a few people with short bowel syndromes, even in busy nutrition units. We have not done any operations to address the short bowel itself. We have done operations to, deal with the underlying disease, all that kind of a thing. But never actually surgery itself, even though it is described. Sir, and as surgeons, we should know about it.
So, Niranjan here.
Yeah.
I wanted to ask you, is according to literature, is there any role for intestinal transplant? That is what they're propagating now for short bowel. And even in Bangalore, there is one surgeon who says he has done quite a few with good results.
Yeah.
So I don't know about the literature.
Yeah, I will come to that in a minute. Not in a minute, at the very end. There is a slide on intestinal transplant, okay, and all the procedures that we have. Okay, yeah. So when we talk about nutritional support, that to oral, this is what I mentioned. Some food in the gut is important. I'm repeating it so that all of you understand. You can just start off with just fluids and electrolytes. Do not give them regular food, but you have partially digested food available. Perhaps not in India. I have not seen it, even though I have known of elemental diet available in India. You can give oligosaccharides, dipeptides, and medium chain triglycerides instead of long chain fatty acids. Long chain, that's the regular fat that we eat. And then if you have elemental diet, it is completely digested. You break down these things into glucose, amino acids, and fatty acids. Then you give it to them. Elemental diets, not easily available, but you can look for it and it is available. I'm told, even though I have not used much of it, but it is available here. And so you have to think laterally. Start with just fluids and electrolytes, and then look for partially digested food, which, as I said, is difficult in this country. But elemental diet, I'm told, is available, and you can look for it and try and give it to the person. This, remember, is in addition to the parental support. So, what are the factors that you think of in parental support? What I'm talking about is all of them need parental support. That's why that by definition, short bowel is that. Okay. So the oral part is supplemental to start with until adaptation completely occurs. So when you look at parenteral nutrition, what are your primary concerns, primary issues that you have to deal with?
Sir, central line and venous access.
Okay.
The
Caloric
cost of
need.
total parental nutritional.
Sorry, cost, very good.
The needs, the caloric needs of the patient, sir.
Yeah. You can calculate, you can calculate and give them the calories, the carbohydrates, the fats, all that is, in fact, ready-made bags are available. So central venous access is one, and the problems associated with it, the metabolic problems of parental nutrition, and the infective problems that come with parental nutrition. These are the three things that you must have in mind. All right. And to address these things, you must, in your mind, look at short-term, long-term, or a permanent need for parental nutrition. Take it from me, in India, I don't think you can manage long-term or permanent parental nutrition. I've had situations where we have not had patients surviving or even affording that kind of a thing. Short-term is something that we have done quite a few times. And so to facilitate this, what are the kinds of central lines that you would think of? Go on. Samir, what are the kinds of central lines that you know of?
Sir, because we are thinking of long term, mostly will be tunneled catheters are preferred,
Okay.
sir.
But tunnel from where to where? Minus?
So, tunneled only, sir, and the PICC,
Okay. I've given you the answers already. Subclavian line is the commonest. For feeding, it is preferred to internal jugular. Okay. So you do a infraclavicular subclavian is the best, most comfortable, the best managed line. That can be slightly tunneled. Place a gap between the skin entry and the vein entry. You can have a PICC line, peripherally inserted central line, where you go from the cubital fossa, or you can have a completely indwelling line, like the chemoports. Okay, this is what we use for long-term or permanent TPN. It's just a little port that is buried under the skin, attached to a central line, so that the patient himself can prick that area and feed himself through the night with a daily dose of his nutritional requirement. And the next morning, he unplugs it and goes away, does a normal day's work, and comes back and hooks himself onto this feed, peripheral, the parental feed through the night. Okay. We have actually seen these done in Boston, where I worked, and I'm sure Ravi would have seen it in Manchester. But in India, I've never seen it or done it. It's because it's just not physically possible to maintain these and economically possible to maintain this. Okay. So we then come to the complications. I told you one of the basics that we need to understand about treatment is A, nutritional support for the short bowel, B, supporting the metabolic issues, which we'll come to when we come to the medical treatment, and C, dealing with the complications of the treatment. Okay, and the complications of parenteral feeding are quite a few. I mentioned about the headings. What are the things that I mentioned, Samir? Just now I mentioned 3 headings under which you should think of.
Catheter related, sir.
Yeah. What catheter related what?
In the complications of catheter.
Complications of parental nutrition. So catheter related, what are the complications catheter related?
Sir, the pneumothorax, hemothorax.
Mechanical.
Mechanical.
I keep saying you must organize your thoughts. Okay. Mechanical problems. Second,
infections.
Infective complications. Okay. And what else can you get with TPN? When you put 25-50% dextrose into the patient, and I and Sanya were talking about other problems, particularly after 3 to 6 weeks. They're called metabolic problems, right?
Hyperglycemia.
Yeah, hyperglycemia, hyperlipidemia. If you use a lot of lipids, you can have, microglobules or lipids circulating. And if you actually take out their blood and then, if somebody on parental nutrition, if you take out the blood and just see the serum, it will be like milk sometimes. Okay, and that has very serious implications in that you cannot get a proper measurement of the electrolytes. Okay, it interferes with the measurement in the machine because of the fat microglobules that you have with parental nutrition. So you're talking about mechanical and metabolic. Infective is a third major heading. I'm not getting into it right now because there's a specific way of doing it, and we'll do it when we talk about TPN. Okay, so the mechanical part is blockage, displacement. It can get cut off. The tip can get cut off. The whole thing can get cut off, and get an embolism, pneumothorax, or a hemothorax. Metabolic, hyperglycemia, hyperlipidemia, vitamin and mineral deficiency, trace element deficiency, and infection, of course. Okay, it's not strictly under metabolic, but you can have infective complications. Yeah, go on, Ravi.
All this has been covered, sir. I did a full class on TPN.
Right. That's why I didn't. That's why I didn't. I just put it up so that you know that you have to discuss it under these headings. Now, pharmacotherapy. There is a role for medication. Surgeons must be aware of these medications and why you should use them. That's an important thing. And so what are the things that you thought, I can give you a hint to say that it has to do with the special situations associated with short bowel syndrome. Okay. So, Praveen, have a go at it.
Sir, anti-motility agents, anti-secretory agents. Sir.
Go on. First, talk to me about why you use them and what secretion.
Sir, anti-motility agents, it reduces the transit time, sir.
Okay.
Increases the absorption.
Okay.
So, most preferred agents are loperamide, dexaphosphate, codeine.
Okay.
Sir.
Agreed.
And anti-secretory agents are proton pump inhibitors, histamine 2 receptor antagonists. It reduces the gastric secretions.
Good. What else? All right. So it's not only gastric hypersecretion. You should also think of intestinal secretions. I know that there is not enough length of the intestine, but whatever is there may also increase its production, may have significant production, and it may not be absorbed. So you can use octreotide. Nikita, you're saying something. Nikita,
the pharmacotherapy to enhance the adaptation, sir. The growth factors and recent advances for the adaptation thing, glutamine related, yes.
Right. I'll just make a brief mention, but its role is not well established. As you rightly mentioned, anti-motility agents, loperamide, diphenoxylate, and opioids. Okay. Another class of drugs that you have to use, which can increase absorption. Okay, pancreatic enzymes. That's what I had in mind. There's always a degree of possible bacterial overgrowth, particularly in not the intestinal loss ones, but in patients with obstruction. In those cases, you can use anti and probiotics. We talked about bile acid binders. Enterohepatic circulation gets increased, and so you can use cholestyramine. And this is what you're mentioning about, Nikita. Intestinotropic agents like glutamine, growth hormone, and GLP-2 analogs. Not commonly used, role not completely established, but definitely anti-secretory, anti-motility, bile acid binders, pancreatic enzymes, antibiotics, and probiotics. Definite role is there, and you can use each one of those classes as the need arises. Okay. Next, we talk about surgery. This is where we first talk about the principles. Okay. What are the things that you can do? You're left with a short bowel. One of them, obviously, as Niranjan mentioned, is a transplant. You can transplant the whole thing. But short of that, can you do something to increase the absorptive surface?
Lengthening of the bowel.
Okay. How do you lengthen it? How do you lengthen it?
That serial transverse enteroplasty. We make the cut in alternative cuts in the bowel, and we try to lengthen,
Yes.
or we can just cut the bowel longitudinally, and then we can anastomose, like we can cut it in a halfway and then take the other half and increase the length and anastomose.
Correct. Correct. You increase the length but reduce the diameter. Not so
Yes,
bad
sir.
as to cause obstruction, but nevertheless you increase the length. That's one of them. Yeah. Anything else?
Distal
only one
bowel, if
more.
it is there, which we can
See,
reuse.
you can mechanically, surgically increase the transit time. What can you do for that? Same technique that has been used in dumping.
Reverse anastomosis, sir.
Reverse loop. Okay, so those are the available thing. You can slow down the transit. You can increase the lengthening. You can expand it. Not very common. And you can transplant. These are the things that are available. Okay, and you can use a reversed small bowel or a colonic segment as shown here. Okay, make a little segment 10 centimeters long and then reverse it so that the peristalsis direction changes, and that will increase the time of transit in the proximal bowel, in this bowel, wherever it is. You can have a similar thing with the colon, and that again does the same job of slowing down the transit. Or okay, you can plicate it like this, simple enough. It's not lengthening, but it is in a way an expansion. Okay, so that you're increasing the surface, and either that, or as I said, you can lengthen it by cutting it into half, and as I said, stitching each one of these. It becomes a smaller tube, but not, as I said, small enough to cause obstruction. Okay, so that can also be done. I haven't done any of these, and I don't think it is commonly practiced, but these are things that are being tried. And I haven't put a special slide on transplant other than to mention that transplant is available. Niranjan, all the data that we have so far does not support intestinal transplant that I know of. The number of problems that they have with it is quite a lot. And, Philip Thomas, who was in St. John's, has probably spent his lifetime in Mayo doing intestinal transplants. It is being done. It has shown some marginal success, but has never reached mainstream surgery. So people are still on home TPN rather than a transplant. Okay, so you can read up about it. I have done some reading about it even quite recently. The data are not very promising.
Yeah.
Okay. Ravi, you have anything to say?
I think the main reason that the intestine is the largest immunologic and very immunogenic organ. So the rejection rates are extremely high.
Correct.
Even if there is no in the sense the bowel becoming black, I think the absorptive
Metabolically, it doesn't.
metabolically it doesn't work.
Yeah, very true. Niranjan, you have anything to add? Whatever you heard, but from this
Nothing.
person.
I'm really not gone through the literature.
Yeah.
But in the Bangalore Surgical Gastro meet in 3 months back, that surgeon from BGS Clinicals, he presented his data of I think 4 or 5 cases, where he said the results were good, and he had shown some literature review when there is no other option. This is probably the only option.
What was the length of follow-up, Niranjan?
The length, I think
his
he
cases.
said 6 months. 6 months minimum.
I
Get
see.
told.
Okay, that's a reasonable month. Yeah. Anyway.
So that is what I have not gone through the literature. That's why I asked you.
Yeah. But generally, across the world, the literature is not very encouraging. Okay. Yeah. So,
sir, be this about the lengthening procedures. It seems to work a bit better in pediatric age group, especially kids with necrotizing enterocolitis and atrasias, and I think volvulus, and where they lose the bowel. There was because Manchester Hope Hospital was linked with the Manchester Children's, and there was a very good, very renowned surgeon called Adrian Bianchi. He is the person who's done a lot of work on.
There's an operation after his name, Bianchi procedure.
Yeah, Bianchi. So I have seen him operate, and he's done a lot of this bowel, the lengthening procedures, which seems to work in kids a bit better than as well.
Okay. So the take-home message is simple. By definition, short bowel is if it's less than 200 centimeters. It could be less than that if the IC valve and the colon are present. Please remember, apart from the fluid and electrolyte losses and nutritional deficiencies that may occur, there are important metabolic issues that you have to bear in mind. There's a definite role to learn about nutritional support and pharmacotherapy. Some food in the bowel is important, even if there is malabsorption, and surgery has a very small role. Okay, that's about short bowel syndrome. As I said, I don't think you'll see too many of these cases in your career as a surgeon, but it's important to have all these points in mind. Comments, questions from the students? All right, from the registrars. Nikita, you want to say something?
Sir, I just wanted to know the incidence, sir. Like, how many cases have you come across short bowel syndrome?
In India, in 35 years of practice, I've seen only 5 cases. None of them survived.
Is it because of the background disease of Crohn's or the complications, sir?
No, lack of nutritional support.
I had only one case of Crohn's with a very bad multiple resections, only one case. Okay, in India, I'm talking about India. It's much more in the West when I practiced there. But the others were all mechanical problems. Okay, one of them was a horrendous case when nearly the whole of the small bowel was pulled off from its mesentery, thinking it was a cord. Okay, during an abortion procedure. Okay, it was really a very funny situation. Not funny, but very dangerously funny situation. Okay, that was one extreme example. All others were ischemic bowel. The other 4 were all ischemic bowel, where we thought the patient would survive. That's why we did a resection anastomosis with I always do a mandatory second look operation in 48 hours. The anastomosis survived, but the patient just could not be maintained nutrition-wise and developed septic complications and died maybe anywhere between 2 to 6 weeks later. Yeah, that's my personal experience in India. Ravi, your experience?
Yeah, I think we had about 250 home parental nutrition patients, largest home parental service in the world. at Hope Hospital. And I think even there it was so difficult to maintain these patients. Despite, it takes about anywhere between 3 to 6 months to train the patients to look after their own lives and, sepsis free and things like that. It's so very difficult. And then you have all the metabolic problems and things. So I think India, it is still, a pipe dream to think that we can provide sepsis-free nutritional support, and one is the expenses, which is second extremely important factor. I think one of the things which I sir, to add to sir what he kept saying very importantly to early feeding. I think what we would do is even with patients with fistula, you identify the anatomy and ensure that there is no distal obstruction and feed the proximal content. What is the chyme that we used to get with the bile and the pancreatic juice and all that, and succus centricus, and add filter that and add the semi-elemental or elemental diet, or even the normal diet, and feed it to the distal bowel. And if you start doing this early, you can take off many of these patients from complete dependence on TPN, or at least, as you said, they can be fed overnight, and during the day they can be free and they can run their normal life. So I think early feeding of the gut is very important because it will set off the adaptation much earlier.
Yeah, sure. Any other comments from the registrars, Nitya, Sanya,
Sir,
Kritika? Yeah, go on.
I have a doubt. Although we didn't talk about surgery in length, but when we had to talk about cutting the bowel into two and then making the diameter less and then joining, how do we take care of the vasculature, sir? Like, because mesenteric border, how do we do that cutting? Like, I don't know if it's a correct question to ask.
No, it's a very correct question. Each time, the mesentery has two leaves.
Mm-hmm.
Okay,
yes, sir.
Always. And the blood supply also goes like that on either side. Okay. So you cut it longitudinally, and each half of it will have blood supply from that leaf, that half of the leaf of the mesentery.
Okay.
That's the way it works.
Okay.
Yeah.
Okay.
Sir, I had a doubt, sir.
Yeah.
Sir, let's say we're in an operating situation where we find out that on table we do a major resection and there's very less bowel, like maybe very few centimeters of jejunum. So at that point, should we really do a jejunostomy, or will it make any difference at that?
That's a good question. That's exactly what we said. If you find that the whole of the jejunum is gone and you do not even have 50 or 60 centimeters of the bowel, you should do nothing. Close and get out.
Yes, sir.
Yeah, that is the point, because it will be unkind to do a resection, and
Yes.
You can't give TPN for long. You have other complications, all kinds of complications. The patient will have a miserable time. Rather, you close the abdomen, tell the family about this, and allow him to go peacefully and comfortably.
Yes, thank you.
Giving him palliative care. That is why that particular slide, that information about the presence or absence of ileocecal valve and the colon and the relationship of the length of the bowel to these two factors. That's why it's very important.
Yes.
Yeah. Niranjan?
Sir, nothing, sir. It was excellent.
Yeah. All right. Closing comments from Ravi, and we'll.
I think, as sir said, short bowel syndrome is not something that you encounter frequently, but when you do, I think pragmatism should be the guiding force. As sir said about, how much we can do and how much can the patient afford, because I think it's important that we cannot have actually a system where we can feed these patients, infection free for a significant period of time. The acute short bowel syndrome we can manage well, but chronic ones, I think it's a very difficult thing, and sir has highlighted all that very well. So I think when you have a situation like this, you have to probably discuss it with somebody who has dealt with on a regular basis and then take a call. Thank you very much.
That's an important point, Ravi. Thank you for mentioning it. I should have mentioned it myself. When you make a decision not to do anything more, it's always good to involve another surgeon to back your decision, however experienced you are, because you are basically, deciding the fate of the patient. So it's always good to have another person thinking alongside you. And so I always, it could even be an experienced registrar. It need not necessarily be another consultant. People who have done a few years of surgery, who know what they're talking about, have read up about it. So have another person with you to take a decision when you decide to close the abdomen without doing anything. That's a good practice to have. All right. Thank you. Good night. And
thank you, sir.
yeah, thank you.